Hello everyone, it's my honor to introduce our speaker. Our first speaker is Miss 𝑁𝑜𝑘. She is nurse in International Brain Center in Jakarta. She works in outpatient department and she's responsibility for neurosurgical division in outpatient department. She have a responsibility to prepare patients who have a plan to have surgery, especially in pituitary tumor. 𝐸𝑛𝑜𝑘 also joined in pituitary community. She is a nurse in the community. She gives advice if the patient have any problem or she want to asking about herself, about her condition. 𝐸𝑛𝑜𝑘 will give the time for the patient by WhatsApp group. If the patient have something to ask, or 𝐸𝑛𝑜𝑘 also join the communities and make some event. We have a pituitary event every year. 𝐸𝑛𝑜𝑘 is the responsibility nursing in this community. So in this time, 𝐸𝑛𝑜𝑘 will presentation a case report about care of patient post-transpondal surgery. For Mrs. 𝐸𝑛𝑜𝑘.
Okay. Thank you, Nurse Maya. Everyone can see my PPT?
Yeah, we can see.
Would you slideshow, Anna?
Let's show. Okay.
From beginning?
Okay. Like this?
Yeah, okay.
Yeah, please.
Bismillahirrahmanirrahim. Hello, good afternoon, everyone. Before we begin our presentation, let me introduce myself. My name is 𝐸𝑛𝑜𝑘 Mama Siti Murtasima. I am clinical nurse, neurosurgery outpatient department at National Brain Center. I'd like to give presentation about case report care of patient for transpenoidal pituitary surgery. Sorry. Okay, I will begin by explanation about patient recent paper surgery. She is Mr. F, 37 years old, had transpenoidal surgery on August 19, 2024. As even in patient award, consciousness composementis, and then she had patient problem, worsened since June 2024, blurry on left eyes, myopia on right eyes. And then she fatigue, often feel sleepy, had irregular menstrual cycle, and then headache, feel like pressure since last 6 months, and NO results, hemianopsia bitemporal, prolactin level 50.29 is high, and then thyroid stimulating hormone level on 1.46, and then thyroxine hormone level 7.5 is low, and then cortisol level 2.87 is low. And then MRE at August 13, 2024 is solid like hypercellular mass, the size about 5.7 centimeter at supracellular to intrasupracellular. Okay, sorry. And this is nursing care of Mrs. F post transpenoidal surgery. On 20, oh no, this, sorry. On 17 August 2024, after transpenoidal surgery, Mrs. F admit to post anesthesia care unit at 9:21 p.m. Left nose post-op wound was tamponed. Lumbar drain flash limit 25 centimeter, setting positive 15 centimeter. Consciousness level on sedation, pupil size 2, ETT place, and vital size blood pressure, systolic 89 and diastolic 54. Heart rate 54 BPM, respiratory rate-nya 12 BPM, and time is 36 Celsius. And then implementation, ventilator waning until until extubation, collaboration laboratory hormone level check in following day, and then radiology, CT scan control in following day, monitor neurological status, head elevation 15 until 30 degrees, lumbar drain monitoring, set point at positive 15, monitor CSF amount and characteristic, and then monitor fluid intake, output, and balance. And then at 20 August 2024, Mrs. F transferred from post-anesthesia care unit to inpatient ward at 8:40 a.m. And then she feel headache, vascular, feeling like mucus in sleeping into the throat. And these drains will be greatest for 3 days after surgery because of residual consequence of the operation. But we must still observe the fluid that comes out of the nose. And then blurry on left eyes, myopia on right eyes, compos mentis, vital size in the normal rate, and then left nostril was tamponed, surgical wound was clean, no bleeding found. Lumbar drain flash, 25 centimeter limit, setting on 15 centimeter. Undulation is present, CSF found in the clear red dish. At 6 a.m., urine production start to increase. The onset of polyuria is usually abrupt, occurring within the first 11 until 24 hours after surgery. And then fluid balance, diuresis in the normal, but in the cortisol level is high on 16.04. And high cortisol post-op operation can be psych or post-operation stress, but we should evaluation to identify more serious problem. And then implementation, monitoring neurological status, monitoring field of view minimal 3 times in the day, maintenance blood pressure within normal limit, head elevation 30 degrees, monitoring lumbar drain, and then monitoring CSF volume and characteristic, monitoring intake, output, and fluid balance, fluid restriction 105,000 in the day, collaborate monitoring on 24-hour urine electrolyte level from 6 a.m. at 29 August to 6 a.m. August 22. Observe any leakage in the surgery area, and then collaboration, administer antibiotic, administer hormone therapy, and then tampon plan to remove on 23 August. And then in the 21 August in patient ward, the problem are Mrs. F has fatigue. Fatigue is normal to feel, patient is normal to feel fatigue after surgery 40 until 4 weeks, but we must still observe the other of psych hypopituitarism, like fatigue increase, decrease ability to concentrate and memory, or decrease blood pressure. Blurry. The next problem is urine output. 5,700 milli per day, and duration is 2.9. Because of their problem, so we should still fluid restriction 1,500 milli in the 45 hour, because we want give signal for hypothalamus to return fluid in the normal limit. And then because the duration is 2.9, we collaborate to give administering minerin hormone therapy 0.1 milligram twice. And then the next, on August 22, the problem are fatigue persist, but eyes blurry. But as blurry can be caused by after surgery, like edema or inflammation around the pituitary area, can put temporary pressure on the optic chiasm or optic nerves. Caution vision problem, so we must still observe monitoring field of view minimal 3 times for a day. And then left nostril was tampon, little blood leakage was found and clear enough. So we should do monitoring CSF volume and characteristic, and then collaborate with doctor. And then blood output still high, 4,100, and then blood sodium level is high, 1,050, 153. Hyponatremia can be caused by side effect from diabetes insipidus, because urine output still high. And then we still should fluid restriction. Collaborate for infusion day 5%, 500 cc for a day for 2 times. And then at the 24 August, the problem for of Mrs. F is feel thirsty and nasal leakage still found but reduced in volume. Input 2,045 milli for a day. When Mrs. F felt thirsty and water input was increased, we should discipline to fluid restriction, because this is a sign that we have to warning that there are indication of indiscipline with fluid restriction. We have to re-education patient not to drink more than recommended. And then because nasal leakage still found but reduced in volume, monitoring CSF volume and characteristic, and then collaborate to administration of 𝐷𝑟. Okay. And then this is it. Okay. At August 25, patient have a normal death, headache fast score decreased to 2, no nasal leakage found, and then left eye blurry, right isolate return to normal, compass mentis, and then vital signs in the normal rate, diuresis in the normal, blood sodium level is normal. Before correction was high. And then because of a patient have a normal death, patient discharged from inpatient, and then we as a nurse should give education about outpatient visit schedule, education about increased ECP psych, education on monitoring the amount and characteristic of CSF, educate on intake, output, and fluid balance, safe monitoring at home, provide with a manual fluid monitoring form. Fluid restriction still like before, 1,500 milli for a day, and collaboration in administering minirin hormone therapy 0.1 milligram twice if diuresis more than 2, and then geneson 20 milligram twice. This is from manual for patient to write the input, the output, and then they apa ya, menghitung ya? They
Bisa lanjutkan aja, Nok.
do the resist ya.
aja.
And this is a instruction when minirin when you resist less than should don't eat minirin. And then let's move to the journal. Sorry. Okay. On the journal, optimizing pre, intra, and post-operative management of patient with cellular pathology undergoing transplant surgery from David et al. They say only rare will post-operative patient required admission to the neuroscience ICU. So in our hospital, most of the patient after operation admit to post anesthesia room and then move to inpatient ward. And then in the same journal, they said recent evidence suggests that use the perioperative lumbal drain is effective in reducing the rate of post-operative CSF leak in patient undergoing endoscopic endonasal surgery. Okay, sorry. As a nurse, we must understand how to properly observe and monitor patient as well as manage lumbar drain to prompt identify any issue that may arise. And then in the same journal, fluid intake and outflow are monitored closely during the post-operative period to assess for fluid retention or diabetes insipidus. And visual field check are performed at least 3 times daily, both of identify post-operative adverse event such as hemorrhage and also to monitor for symptom improvement. And then this is post-discharge instruction for patients who have undergone transplant surgery, restricted oral fluid intake, and then only drink when thirsty, saline nasal spray at least twice per day, and then no bending of lifting more than 30. And then report any of the following symptoms: nausea, vomiting, fatigue, severe headache, still neck or fever, excessive thirst and frequent urination, and clear nasal drainage with headache. This is the other journal, current best practice in the management of patient after pituitary surgery. In this from Alessandro Fried and et al. They say hypernatremia is highly suggestive for in diabetes insipidus. And according to the most case series, diabetes insipidus is most common complication after pituitary surgery. It occurs in approximately 10 until 30% of patients undergoing pituitary surgery, but it persistent long-term only in 2 until 7%, with approximately 50% of patients remitting in 1 week and about 8% in 3 months. And the onset of polyuria is usually observed occurring within the first 11 until 24 hours after surgery. And then in the same journal, they say management of perioperative CSF leak. When to suspect clear, watery nose discharge, usually unilateral, the patient may refer salty or metallic test, headache may occur, or infectious meningitis develop other signs and symptoms, fever, severe headache, neck stiffness, and confusion. And then bed rest with head and torsatil of 15 until 30. Stool softener to avoid increased intracranial pressure during bowel movement. Avoid action that can lead to increased intracranial pressure, causing sneezing, nose blowing, or heavy lifting. And then lumbar puncture and CSF drainage can be useful to reduce intracranial pressure. This produce can something blood CSF leak. Okay, and some other suggest give antibiotic prophylaxis to prevent meningitis. This is on neuroendocrine. TSS post-op interaction from Harvard University, Dr. Harvard University, they said that fatigue is normal to feel fatigue after surgery for 3 to 4 weeks. And nasal drain, you can expect some bloody mucus drain from your nose. This drainage will be greatest the first 3 days after surgery. Okay, patient undergoing transsphenoidal surgery require careful and multidisciplinary postoperative care to monitor the potential side effect or complication. Quick and afrometally treatment can prevent unwanted damage. That's all I have to say about. Thank you.
Thank you, Miss Anna. Can we leave to comment or question later? Now, can I call upon Prof. Kurosaki to introduce Prof. Kusako Amano? Prof. Masamichi?
Yeah.
Kurosaki? Please.
Can you hear me? Okay.
Yeah, we can.
So now I will start with our session, okay?
Yeah, please.
Okay. It's truly an honor to chair this session. My name is Kurosaki, Tottori University from Japan. I'm the chairperson, and in this session, we invited Professor Kosaku Amano. He is specialized in pituitary and paracellal region tumors, and he's now Associate Professor, Department of Neurosurgery, Tokyo Women's Medical Universities. His topics today is the surgical treatment for pituitary disorder. So please, Professor Amano.
Can you hear me? No voice?
ちょっと小さいかな、声が。
声が小さい。聞こえてはいますか？
聞こえてる。
そんなに声小さいですか？
もうちょっと。
でも小さいです。
小さいですか？これで声が、
いっぱいにしていいんじゃないか。いっ
ぱいにする。これでも小さいですか？全然小さい。
聞こえますけど小さい。
小さい。じゃあ大きな声で喋れば大丈夫ですか？
どのくらいだったら大丈夫です。
OK。Okay. Sorry for disconnection. My topic is surgical treatment for pituitary disorder and postoperative precautions. Pituitary is located here, the center of the head, and located deepest in anterior skull base. It's so far from surface of head and face. So how to approach for the pituitary region? There are several approaches like this. But recently, transphemoral surgery is common. Maybe more than 90% surgery were performed using transsphenoidal surgery. Because we don't need to retract of brain and artery. However, it is narrow and deep corridor, so maybe this is one of the most difficult surgery in neurosurgical field. So first of all, we must know historical background of transsphenoidal surgery. It had started at the beginning of 20th century, and famous Dr. Singh, he said, because of high mortality rate, high complication rate, this operation transferred to transcranial surgery, open surgery. So it was once abandoned. But 30 years later, Dr. Hardy introduced the microscope to this operation, and it became a safe surgery and progressing now. And since 1990s, endoscope was introduced, now developing more and more. So we must know this surgery had once gone out of use because of complications. So also we must know the anatomy. Pituitary is surrounded by so many structures: pituitary gland, anterior lobe and posterior, and stalk. And the superior part, there is optic chiasm, nerve, ACA, superior hypophyseal artery, hypothalamus, and anterior on the caudal side, nasal cavity, sphenosinus, sphenopalatine artery, olfactory nerve, fibers, and bilateral side, there is a cavernous sinus. And inside of cavernous sinus, there was an oculomotor nerve, trochlear nerve, abducens nerve, and intercauda arteries. And posterior to the pituitary, there are vaginal artery, mammillary body, and brain stem. So these structures are so important because human and animal, important thing is that at the center, and the pituitary is center, so it is difficult. So how about the complication during after TSS? These are representative. And I reviewed 12 years ago these complications after the transplant surgery. And 30 years ago, there was a national survey in United States, complication of transplant surgery. They said there is a running curve in complication of TSS. For example, CS leakage, it occurred average almost 4%, but beginner 4%, and experienced neurosurgeon less than 1%. My personal experience was 0.2%. This difference is a big problem. So my experience is more than 1,300 cases. I made many surgical innovation in instrument, in technique, and also, most important thing, complication avoidance. That lead to the current endoscopic TSS. So this report, I show you the current endoscopic TSS and think about the possible precautions. So this is one of the revolution of the TSS in instrument, high definition type endoscope. TV become high definition, and also endoscope become high definition. It has 7 times higher pixel than conventional type. It can detect even the flow of RBC, and it means a close-up mode equipped. So how about the endoscopic TSS advantage? Microscope can see only this region, but endoscope can see this wide view. And also, HD endoscope equipped the close-up view. Closer to the object, we can get close-up view. And far more go to the supracellular region, we can get such a close-up view. It changed the TSS drastically. And recently, 4K, it means 4 times higher pixel than HD endoscope. And ICG, it can detect the vascular and tumor cleavage. It is an outstanding, promising tool. Maybe it developed the TSS more and more. And also, we can see the object, but we can see but remote tumor is a different because we need a novel flex, malleable, bending tumor instrument to remove the tumor. We developed this instrument. So I show the representative pituitary disorders. PituNet recently changed the name. Maybe you know that as pituitary adenoma, and atopic cleft and craniopharyngioma. So how about the surgical indication of pituitary adenoma? It means non-functioning and functioning adenoma is different tumor. Non-functioning adenoma, visual impairment is the surgical indication. The purpose of the surgery is to improve visual dysfunctions. But recently, add the hormonal dysfunction to improve or preserve pituitary functions. On the other hand, functioning pituitary adenoma purpose is to make hormone excess normalized. So it looks same, but the different tumor. So the non-functioning adenoma, we must remove 90 to 99%, not to make complications, but improve the visual impairment. But functioning adenoma, we must remove it more than 100%. We try to remove the tumor completely. That was different. So this is a non-functioning adenoma, 8 years old, very old patient, apoplexy. He demonstrated a visual disturbance, right hemiparesis, paralysis, conscious deterioration, and he had heart disease. So anesthesiologist said, you must finish the operation within 2 hours. So tumor is enlarged to the third ventricle, but we must kill the TSS to shorten the surgeries. So this is a tumor. Look upward using the angled endoscope, and this is a apoplexy case. So a tumor contained such a hematoma, and the tumor was so fibrous, and like this, tumor removed as a emblocked, like this. So we can reach such a center of the brain using endoscopic transfemoral surgery. This is a third ventricle. Tumor was completely removed and no complications. And since 2008, I try to improve and preserve pituitary functions. In this case, there is a mild visual disturbance and also pituitary dysfunctions. So at first, I want to find the cleavage between the tumor and normal gland here. But using a HD endoscope, we can find another membrane like this. So I peel off this membrane from tumor because this is originally normal gland, but become fibrous because of the compression by the tumor. So only the tumor was removed meticulously and preserved the normal pituitary gland. And at the end of surgery, this membrane becomes thick and retinous because it means revascularized. After the surgery, tumor was completely removed and normal gland preserved, visual impairment improved, and also pituitary dysfunction was improved. So how about functioning adenoma? This is the growth hormone producing adenoma, acromegaly. So tumor invaded into the cavernous sinus beyond the ICA here. So it looks difficult. At first, the mid of the tumor removed and changed to the angled endoscope. and the far lateral side tumor was removed. This is ICA. So this is the inside of the cavernous sinus using the angled suction and the ring curate. Now I remove the inside of the cavernous sinus, not to injure the ICA, and remove the tube. So at the end of surgery, this is a normal gland. This is the packed material inside of the cavernous sinus. In this case, tumor was completely removed and pituitary dysfunction not occurred. This case is smaller than previous case, but more difficult than previous case, because here is the inner wall of cavernous sinus, and the tumor embedded into the cavernous sinus, but still cavernous sinus will survive. So there is much bleeding, more than previous case. So under controlling the venous bleeding, we aggressively remove the tumor. Here is the ICA here, and the much bleeding from cavernous sinus, and the packing material prepared surrounding the surgical field, and packed immediately, and keep going on the inner membrane and the tumor. And also this case was completely removed. So next case is 𝐷𝑟.𝐾𝑜 shift. She demonstrated severe headache, visual disturbance, and pituitary dysfunctions. So 𝐷𝑟.𝐾𝑜 shift, it contained some mucus like this, and remove the mucus and sucked. After that, endoscope inserted into the cyst wall and irrigated using the saline repeatedly. This is a warm saline, and remove the mucus like this, and some mucus was adhesive to the wall. So using a ring curate, this mucus was removed and irrigated again and again. Maybe more than 1 liter of saline used. And I removed the membrane, a ritual, because of the further histological findings, and suited the membrane to the dura not to be accumulate the mucus. And after the surgery, tumor shrinked and visual intervals improved, and also her pituitary dysfunction improved. Cranioharyngioma. This is so difficult tumor because easy to recur and adhesive to surrounding structures. So this is so difficult. And this is the conchoid type, between the here is a bone, no certain sinus, but drilled out using a dedicated drill and reach the tumor. At first, remove the calcified region, and the membrane was dissected from a surrounding structure. This is the optic nerve, and here we can see there are so many vascular superior hypophyseal artery. If injured one of these artery, she got the visual disturbance. So all these small vascular must be stopped. And this is a stroke, optic nerve. Here is a vaginal artery. All normal structures were preserved. And she demonstrated almost blind right eyes, but improved. Next case also, right side is blind and calcified so much. And immediately he underwent the TSS. This is the old tumor. And this case is different from a previous case, so adhesive to the surrounding structures. So after the internal decompression, calcified region was removed like this. This is the calcified tissue. I must peel off the tumor membrane from the surrounding structure. This is the arachnoid membrane. Maybe behind here there is an optic nerve, arteries, and so many structures. But like this, using something that force to them to peel off the membrane from the surrounding structure. So adhesive. And here we find the optic nerve and some surrounding perforated here. So I check the ICZ to preserve those vasculars. And after remove the tumor, using the ICZ, we check the vascular. This is the optic nerve and the ACA and ICA. If we use the ICZ, we can preserve such arteries. And also, we remove the tumor totally, and the visual disturbance. So this is a 25 years old woman. She was just married. Of course, she wants to have a baby, so we must preserve the pituitary functions. And here's the pituitary gland, and there is only 5 or 7 millimeter gap here. So we must normal gland pull down. So this is a tumor optic nerve normal gland. So here we pull down the normal gland to make a space, make a gap here. And the tumor was resected meticulously and check the surrounding structures. Now I peel off the tumor at the caudal side. And here is the perforator from vaginal arteries and cut piece by piece. And here is a mammillary body. So moving the tumor, keep going on the surrounding structures. This is the vaginal artery and mammillary body. And look upward. Here's the ACA and perforator. And the hypothalamus here. So she just married, so we try to preserve all functions, not only a pituitary, but cognitive function and visual disturbance. All functions we must preserve. Of course, this case, some original tumor here, but almost tumor was removed like this. So here's a regional tumor, but recent radiation therapy is also progressing. So after the radiation, tumor disappeared completely. So these complications after TSS, these complications, I request the nurse check after the surgery. It means post-operative precautions. Nasal complication. Important point is nasal breathing, because nasal breathing must be, we have to stop the breathing. They cannot aspirate. Pituitary dysfunction. Until pituitary gland dysfunction is chronic, so not so severe. But the diabetes insipidus and the hyponatremia is sometimes become a crucial complication. So please check the urinary volume and specific gravity. And the hyponatremia, it causes cerebropontine neuritis. It's very serious complication. So if the patient present nausea, vomit, headache, and impaired consciousness, please check the electrolyte, natrium or kalium and phosphorus. Some young neurosurgeon said, "Oh, please check CT," but that's wrong. Please check the electrolyte. Visual impairment. That's because of the overpacking of fat to prevent the chest leakage or hemorrhage after the surgery. So please nurse check the visual acuity on each eye. No bilateral eye. Each eye is important. And if you find the visual impairment, please call the doctor, and it means the emergency surgery. Cranial palsy. This symptom is double vision, diplopia, and ptosis. It's different from the reason, but most of the cases we do the steroid administration. And some case we need the emergency surgery. So double vision, ptosis is a sign of you must call the doctors. intracranial hemorrhage, represented with our hemorrhage in the regional tumor. It often occurred, especially beginners, and subarachnoid hemorrhage, and chronic subdural hemorrhage. All these hemorrhage after the surgery demonstrated impaired consciousness, hemiplegia, headache, and visual impairment. So if patient presented these symptoms, we need a CT, and most of the cases, we need emergency surgery. So take-home message, we must know how to prevent complications, and we must know precautions for various complications. We doctor prevent complications. And please nurse, I request nurse, take care the precautions. Pituitary tumor are benign tumor, so we must prevent the complications. Thank you for attention.
Thank you. Thank you very much for a nice presentation, Professor Amano. And let's move on to the discussion time. The commentator, Dr. YouTube or Dr. Selfie Oswari, some comment or question?
Thank you very much, Kurosaki Sensei. Yeah, and congratulations, Amano Sensei. As usual, beautiful presentation. I learn a lot every time I watch you present or teach or giving lecture. So, in terms of the perioperative in the nursing care, how is it in the protocol for pituitary surgery in your department? How is, for example, do you often do the hormonal assessment in day 1, day 2, day 3, or which kind of hormonal, especially for the non-functioning pituitary adenoma? Because I know that in several places, several departments, it will have different protocols in assessing hormonal assessment afterward. And do you routinely give the hydrocortisone, or it depends on the preoperative? Would you mind explaining more about the perioperative, especially for the nursing care? Thank you.
But I don't know if it's correct or not. So we must ask the endocrinologist. So we routinely
The voice is so low. Please. 聞こえにくいです。
we use hydrocortisone routinely, but I don't know if it is correct or not. So that's know the endocrinologist. But we routinely use the hydrocortisone. So I request the nurse to check the hyponatremia and diabetes insipidus. That's most important thing. Hydrocortisone is we routinely use, so we don't need to check. Can you hear me?
Yes, yes. Thank you, Amano Sensei. How about the fluid restriction? In our department, Nurse Enoch, the one that present in the beginning. So we usually ask the patient, especially the 50 to 60 kilograms patients, we ask them to restrict the fluid intake in total around 70 to 80%. So it's more or less about 1,500 cc. How about in your department? Do you do all the fluid restriction, or it will be depend on the natrium, or how often would you ask for the natrium assessment?
So the control of the pediatric group patient is so difficult. I don't know the good answer, but some doctor said check the body weight. That's important for controlling the pediatric patients. So check the natrium and how much infusion. That is different from the patient, especially the less than 5 kilometer, 10 kilometer shared foot. We need to check the body weight.
And then will you restrict like 70% or 80% from the normal fluid intake, or will you just give as usual 100% of the fluid needs daily? Do you restrict in total?
Such a volume is, to tell the truth, doctor of the pediatrics control. So I don't know in detail, but I know that the how to do that. But the important thing is to check the body weight. I'm sorry.
Thank you, Sensei. Because usually in our department, especially in Indonesia, I think Nurse Enoch can explain furthermore. It's not easy to make the patient engage to the treatment. So we need to motivate our nurses. Usually, will motivate the patients to do the fluid restriction in order to prevent the DI in the early stage post-operatively. Because sometimes some patient they just don't want to collaborate in the treatment actively, so they drink a lot, and that it will cause, of course, the natrium imbalance. And I think our nurses is doing a great job in motivating the patients to do the fluid restriction in the couple of days right after surgery. Okay.
Thank you, Selfie. How about Dr. Yo to Boo?
Prof. Kurosaki, Dr. Wu is not in. I think he cannot make it because he has an emergency surgery. He just emailed me.
Okay. How about Dr. Yi Chen? Do you have any comment or question?
Prof. Amano, is a very informative lecture. Thank you very much. I learned a lot from your lecture. Just wonder what is the best position for patient after transsphenoidal, Prof? The best position post-surgery. What is the best position for patient post transsphenoidal?
How
Sorry, I
about
don't
Dr.
understand
Amano?
meaning of position.
She asked post-operative positioning. Maybe.
Position the bed up or not?
Yeah. That's right.
Oh, if we restrict the wake up or not is CS leakage. So recently, we rarely experience CS leakage. So the day after the surgery, the patient can wake up and take a food, and the day after, day one, the patient can walk.
Because I understand a lot of centers in Malaysia post transsphenoidal, we nurses were told to advise patient to lie flat. I think which is very uncomfortable.
So 15 years ago, 1 week bedridden, but recently, no, restricted. So that is because of the complete prevention of CS leakage. So bedridden is the purpose is to prevent the CS leakage. So our case is seldom occurred CS leakage. So the patient can wake up and walking day one.
Thanks, Prof, for sharing. Thank you.
Okay. And Professor Amano, my question is about the cases with cavernous sinus invasion. You talked about functioning adenoma surgical technique, removing the intercavernous tumor. How do you treat with the non-functioning adenoma with cavernous sinus invasion? How do you think?
I think if the patient presented a cranial palsy,
Mm-hmm.
ptosis, or diplopia, we must remove the tumor aggressively. But except that, I think we don't need that. And after the surgery, 10 years ago, I used a radiation therapy for the radiation tumor in cavernous sinus. But recently, we didn't. Because tumor isolated in the cavernous sinus, in case of a non-functioning adenoma, maybe less than 20% growth. Such a isolated tumor rarely grows. So I think non-functioning adenoma, we don't need to make a risk to remove the tumor.
Okay. Thank you very much for your cooperation. Now I'm closing this session. Professor Yi.
Yeah, thank you very much, Prof. Amano and Prof. Kurosaki, for very informative lecture and for chairing the session. Now we shall continue to the nursing speakers. May I call upon Christine? Christine, are you there, Christine?
Yes, I'm here. Yeah. Hello. My sound is clear, ma'am? Hello?
Yeah, we can hear you. Continue, please.
Okay. Yeah, okay. Thank you, Professor Masami Kurosaki, and all speaker, Prof. Armano and Miss Enno, for the closing the first session and for your presentation. Very, very excellent. Now we will begin the second session with the nursing session. I am honored to serve as a co-host for this segment. It's my pleasure to invite Miss Christina Deborah Semtemaya, who will serve as a chair for the second session. Miss Christina, are you there?
I'm
Yeah.
here.
Okay, Miss Christina Deborah, the floor is yours. Thank you.
Thank you, Ms. Kristen. Okay, I will introduce our next speaker. The next speaker is Dr. Manju Dandapani. She is Associate Professor in National Institute of Nursing Education. She received her master's degree from All India Institute of Medical Science, New Delhi, and PhD nursing from Indian Nursing Council. Dr. Manju has 23 years experience in nursing. She has experience as a neuroscience nurse at All India Institute of Medical Science in New Delhi. She also has experience in Postgraduate Institute of Medical Education and Research in Chandigarh. Dr. Manju very active in Profession Society. She is a Vice President Society of Indian Neuroscience Nurses since 2022 until today. She's also a respected member in Board of Study member at Himalayan University and 𝐷𝑟 PhD Guide in the Indian Nursing Council and Postgraduate Institute of Medical Education and Research. She is also active as a speaker in national and international conference. She also gives her time as editor and review in various journals. Dr. Manju has a lot of publication in nursing area. Her research focus on brain tumor, pituitary tumor, traumatic brain injury, and stroke. In 2023, she gets Outstanding Nurse Research Award in India by Career 360. Today, Dr. Manju will present about care of patient post-transpenoidal surgery. I'm very pleased to present Dr. Manju Dandapani.
Thank you, Christina Deborah. A very good morning to all, especially dignitaries like Professor Yoko Kata, Professor Matron E. Cheng, and the previous speaker and all other dignitaries. First of all, I thank ACNN for giving me this opportunity to present the nursing management of patients who have undergone transsphenoidal surgery. So we have, I was not there in the initial part because of the short notice on the time change, but so somehow I missed the first first case study and half of the first session, which was the surgery. Anyway, yeah, we are also doing a lot of pituitary surgeries over here. I'm a neuro nurse working here, as also working as a teaching faculty in the College of Nursing that is associated with the postgraduate Institute of Medical Education, Chandigarh, Education and Research, Chandigarh. So we are conducting some studies as well on the pituitary patients. So I would just like to share the experience with you all. First of all, I would like to share my slide. Yeah, hope it's visible.
Yes, it's visible.
So you have already seen, we have already discussed the management, surgical management of pituitary tumors, and we have seen the types of tumors, which is functional or non-functional. And if it is functional, the imbalance in the hormonal assay, and all those things must have been already discussed. So depending on that, the nursing management would be little different. But however, pituitary tumors are little different from all other brain tumors because there's a master gland, and the approach that we are using is transnasal transsphenoid, and its proximity to hypothalamus and posterior pituitary. You know that majority of the pituitary tumors happen in the anterior pituitary, and its proximity to the posterior pituitary lobe. And due to the approach of the surgery, there are some certain complications that can develop post-operatively, for which the nurses have to be really alert and vigilant while managing the patient, so that these post-operative complications can be prevented or identified and managed early. So just if we talk about the pre and post-operative care, we will be discussing. The pre-operative care is not much different until and unless it's a functional tumor and they have some hormonal imbalances. So we know that obviously informed written consent is taken after explaining all the risk of complications, and hormonal profile is needed, and maybe some hormone supplements or the antagonist or analogs may be given depending on the deficiency or excessive production. Then pre-anesthesia checkup, blood arrangement, pre-op checklist by the nurse, and psychological preparations, and mild sedation on the pre-operative day, night. And then symptomatic management if the patient is having like headache, or the patient is having any hormonal imbalances, or patient is having visual deficit. Accordingly, the patient will be managed. So the major the issue is related to the post-operative. So as soon as the surgery is over, we know that it may take 2 to 3 hours or 3.5 hours to 4 hours for a surgery. And after that, the patient is usually shifted by the operative team to the recovery room or to the neurosurgery ICU. So as a nurse or as a neurosurgical team, where nurses are the integral part of the team in the ICU, we have to take over from the OT team, look for any intraoperative event like any kind of bleeding or any apoplexy or anything that happened during any other anesthesia related event that happened during the surgery. Then as soon as the patient is received on the bed, we provide oxygen, connect IV fluids, and shift the patient on postoperative bed and connect to cardiac monitor for the monitoring. And we assess the surgical side. Like usually, you know that nowadays everyone is doing endonasal surgeries, endoscopic surgeries. So there is no nasal pack or anything. Otherwise, before when the microscopic surgeries were done, there used to be nasal pack or tampons in place. Nowadays, it's not there. And secured drains if the patient has undergone in very rare circumstances some transcranial surgeries. Otherwise, they don't come with a drain. They may be having a small incision on the thigh from where the fascia is taken for the dural repair. So we have to, definitely assess that surgical site as well. And position the patient, we can provide 30-degree head and bed elevation without neck or acute hip flexion. The positioning was, after the previous talk also it was in discussion. So initially we also used to follow flat position after transsphenoidal surgeries. But now we have changed and now we are going to conduct a study as well. So by providing 30-degree on the 0 postoperative day, and by we are now currently practicing the kind of bed rest, not much ambulating the patient from the first postoperative day, fearing the CSF leak. But we are not providing definitely flat position unless patient is having CSF leak. If the patient is having CSF leak, we provide flat position. So we are also undertaking a research study this year, that 0 day providing 30-degree and first day providing, making the patient ambulatory like any other post-operative patient. So we will look at the outcome in the CSF leak and then we will continue it as a practice. So the immediate post-operative nursing care include definitely always, as always, maintain airway breathing and circulation. We need to ensure that patient's airway, because these patients obviously, you know, that they are conscious and they are worst from OT, and they in very rare circumstances they may come in on a ventilator, but if they have developed any intraoperative events, otherwise they are, you know, conscious patients. So we supply oxygen, and but still we need to monitor airway and breathing and saturation, etc. We ensure that the IV fluid is on and the BP is maintained. Then monitor the vital signs of the patients to ensure that airway, breathing and circulation is all right, and assess for GCS and pupillary response to know the response to an increased ICP, maybe due to a postoperative bleeding or anything. So provide semi-flawless position to the patient, strict intake and output monitoring, because we know that postoperatively these patients are at high risk of developing diabetes insipidus or SIADH following that. So it's very important for us to monitor the intake and output and assess IV fluid and nutritional requirements of the patient. And depending on the patient's fluid and electrolyte, we need to little bit adjust that. And then maintain elimination status of the patient. When we talk about the elimination, yeah, they are conscious and they can be ambulatory. So, but still we have a practice of maintaining Foley's catheter because of the strict intake and a strict output chart, urine output that we need to monitor maybe hourly if the patient is developing diabetes insipidus or SIADH. So we generally do not take out the Foley's catheter on the 0 postoperative day or first postoperative day like other postoperative patients who are conscious. So after receiving the patient on bed and connecting and monitoring airway, breathing, GCS and everything, we have to initially stabilize the patient by providing the postoperative medication, like we provide administer steroid, hydrocortisone and antibiotic analgesics, and any of the PPA we give, usually pantoprazole we are providing. These are the basic medications, and if the patients are having any hormonal imbalance like hypothyroidism, then the patient would be on L-troxin, or if the patient is having other hormonal imbalances, accordingly, the patient would be on medications that would be continued from the which was there already in the preoperative phase. Then send blood sample for routine lab investigations, and electrolytes are monitored TDS, that is 3 times a day for these patients. So, however, their cerebral perfusion we have to monitor, though like it is an endoscopic surgery and endonasal transsphenoidal surgery. The risk of increased ICP is slightly less as compared to a transcranial surgery. So, however, we need to monitor the signs of cerebral perfusion, and we have to take the effort to maintain cerebral perfusion. And signs of any increased ICP we need to monitor. So, ICP may raise due to edema or postoperative intracranial hemorrhage. Monitor signs of raised ICP like headache, nausea, vomiting, loss of consciousness. We need to monitor the GCS, pupillary reaction, and muscle strength and the cranial nerves every 20 minutes for the first 2 hours, every 30 minutes for the next 2 hours, and hourly thereafter. This is our general ICU protocol, which we follow for the pituitary patients as well. Administer steroids as prescribed. Hydrocortisone we usually follow for the pituitary patients. Others we follow dexamethasone. Elevate head end of bed 30 degrees and avoid any neck flexion, hip flexion, etc. Provide calm environment, pain management, whatever analgesic. We usually administer paracetamol. And nausea, vomiting prevention and manage need to be managed, prevent or manage, and prevent constipation and avoid Valsalva maneuver by preventing the constipation. Then the post-operative nursing continue to be, we need to assess for pain and use diversional therapy if the patient is, or analgesics depending on the pain severity by which is monitored using numerical rating scale. Then manage complications caused due to hypopituitarism like Addison's crisis, diabetes insipidus, hypothyroidism, etc. If it is there, we need to monitor for that. Assess surgical sites for any signs of infection, bleeding, CSF leak, etc. Then as nurses, it's very important for us to know the postoperative complications, which is slightly different from other brain tumor surgeries or other craniotomies or cranial surgeries. Here you can see some of the minor complications, which can be hyposmia, there's no loss of smell, nasal congestion, electrolyte imbalance, etc. Electrolyte imbalance is a major complications once it accompanies diabetes insipidus. CSF leak, the major complications include CSF leak, diabetes insipidus, vision loss, and stroke patient can develop. So nurses have to be alert. This is a study, one of the study which is done, which shows that 40% of the patients develop CSF leak and 14.8 develop DA and 10% develop bleeding and hematoma. That's why I told the importance of monitoring increased signs of increased ICP, postoperative nausea, vomiting 6%, electrolyte imbalance 6%. Then other than that, 2 hydrocephalus 3.3%, vision loss, etc. So as I told, CSF rhinorrhea can be developed in incidence of 40%. CSF rhinorrhea or CSF leak. We should not, in fact, call it as CSF rhinorrhea exactly. CSF leak. It is manifested as CSF rhinorrhea or it is manifested as postnasal drip. So we need to ask the patient if they have postnasal drip or frequent swallowing that we need to ask, or any visible leakage from the nostril, which is known as rhinorrhea. So the incidence is 40%, so you know that it is quite high. And it is very important for us to early identify so that we can prevent it, we can manage it, and we can, if it is not prevented, it opens a, direct path from the external environment to the brain, which can result in meningitis. So it's very important for us to manage CSF leak at an early stage. Then avoid head and elevation if the patient is having CSF rhinorrhea or the CSF leak. Anti-meningitis precautions need to be followed. We usually provide injection ceftriaxone 2 gram BD. Then administer Diamox or acetazolamide which produces the production of CSF, so that leak will be. And if they insert lumbar drain, we do a dip dry, lumbar puncture and put a lumbar drain if necessary, so that the pressure is being reduced and the leak is reduced. And care of lumbar, if the patient is inserted with a lumbar drain, then it's important for us as a nurse to maintain the lumbar drain, its positioning, prevention of infection, handling, monitoring the amount, everything. Then surgical repair if needed, that is neuroplasty can be done if it's necessary. So that was about CSF leak. Second most complication is important, and the concerning complication is diabetes insipidus. That is nothing but which is manifested by, that this is due to reduced production of vasopressin from the posterior pituitary due to the impingement in the stalk or due to the compression on the posterior pituitary, which results in polyuria, often of even 4 liters per day, polydipsia and polyphagia, that is excessive. So so we need to strictly monitor intake and urine output. That is very important. Then only we'll be able to identify the patients who are having diabetes insipidus. The patient is having diabetes insipidus, we told that there's a lot of fluid lost from the body, which will result in hypernatremia, the main electrolyte imbalance, which can be again, which can, that this role of sodium in the blood in maintaining oncotic pressure and many other things. So it is again can result in many complications for the patient. So it's very important for us to identify diabetes insipidus and manage that immediately. So assess for electrolyte imbalances, and that is mainly hypernatremia. Administer N/2 or 5% dextrose. Usually we administer, instead of DNS, that is dextrose normal saline, 0.9%, we administer 0.45% of normal saline. So for these patients, and if the patient is developing, hypernatremia, we shift to 5% dextrose. So this is routinely run at a 100 ml per hour rate. But if the patient is having excessive loss, we adjust that accordingly by maintaining 100 to 200 to 300 ml positive balance. So 5% dextrose if hypernatremia is present. Avoid salt intake if the patient is having diabetes insipidus, because they are already at risk of hypernatremia, and adjust water intake and administer prescribed medicine, that is injection vasopressin. So it can be injection, it can be, depending if injection is needed, we provide, otherwise there is spray or tablet which are available. So imbalances of electrolyte, as I told, we need to monitor for hyponatremia and hypernatremia, both can happen. The initial phase, it would be hypernatremia because of the DA, the phase of the diabetes insipidus. But once when we provide vasopressin, when we administer vasopressin, or otherwise known as minirin, what happens? The diabetes, the level of ADH hormone increases in the, or the vasopressin increases, and that results in fluid absorption from the loop of Henle, distal tubules, and prevent diabetes insipidus or excess loss of water. So that is the phase when the patient can go to hyponatremia. because of the excessive saturation of water in the blood that can result in hyponatremia, that is low sodium. And this physiology, it's important for us nurses, for us to understand, so that we will be able to very vigilantly manage fluid and electrolyte imbalance and maintain a normal fluid and electrolyte balance in this patient. So hypernatremia, if the patient is, so these are the signs of hypernatremia, like fresh skin, restlessness, anxious, confused, increased BP, edema, decreased urine output, dry skin, agitation. They'll become agitation, one of the common symptom, confusion, low-grade fever. They'll be very so thirsty. These are some of the this thing. So the manage, restrict salt intake, avoid normal saline, as I told. Otherwise, it will increase the sodium level. Administer 5% dextrose. Monitor urine output strictly. Monitor for dehydration and maintain hydration. So as I told, by monitoring early output, we need to titrate with the 5% dextrose or oral intake. So hyponatremia, if the patient is developing, I told once we administer vasopressin, the patient may develop stupor or coma because of the brain edema that patients develop, because the osmotic pressure, oncotic pressure within the blood reduces and the fluid leaks out to the cells. It will result in anorexia, lethargy, tachycardia, cramping, seizures. Seizures is another problem, major problem. Orthostatic hypotension, muscle weakness. This is also another thing which we have observed. And patient, if not coma, they become confused and stupor. These are immediately lethargy, stupor, cramps, seizures. These all are the visible, we have common symptoms that we see. So restrict fluid intake, 800 to 1000 ml per day if the patient is having hyponatremia. Add salt in diet, 5 gram TDS weekly. Provide frequent oral this fluid we shift to normal saline, and if severe hyponatremia, then we start with 3% normal sodium chloride. And provide frequent oral care to prevent dry mouth, and provide ice chips and sugar-free gums to reduce sensation of thirst. So this is a study which we had conducted, effectiveness of dietary diabetes insipidus bundle on the severity of postoperative fluid imbalance in pituitary region tumors. It was an RCT which we have conducted. Here what we did is, you can see here, with 4 dietary components, that is intake of only water during thirst and avoidance of the following added salt, high protein foods and caffeinated drinks. You know that added salt and high protein diets and caffeinated drinks have the potential to increase the polyuria. So from the immediate postoperative, like there is a tendency that when the patient is started with orally, the patient's relatives gets fruit juices, the coffee, tea with sugar and all those things. And they are supplying, instead of giving water, they think that he's a patient, postoperative patient. So let's supply with all this stuff. The protein, mixed protein supplements, etc., etc. So that feeling is there, and we often see that postoperatively. And because we most of the time give, liquid gradually start to be solid, right? So this kind of tendencies goes on with the patients among the caregivers, and we also don't, stop it. So we have to understand that if the hypothalamus is normally working, because here the pituitary is affected, the hypothalamus, the ADH is affected. Hypothalamus is normally working, it will be able to detect. So as soon as the fluid is losing from the body, there will be thirst. The hypothalamus will be, like producing thirstiness. And if we replace with water, if we just simply drink water, then it is unlikely for the patient to develop hypernatremia. So though there is polyuria, hypernatremia may not be developed. So because this expected DA is kind of inevitable or expected postoperatively. So we preoperatively itself, we educated the patients and caregivers during the postoperative phase when the oral food is started. You should not be giving this fruit juice and lemon juice with the salt and a lot of protein supplements and juice, coffee, tea with sugar, etc. And this was one of the things. And really, this had made a change. And here, like we could find that the diabetes insipidus bundle group had caused a significant decrease in mean daily urine output as compared to control group, because of the limited intake of salt and sugar. The hypernatremia was less common in the diabetes insipidus bundle group, and also which was resolved in a week in the control group. It took a week. And the diabetes insipidus bundle group also needed fewer vasopressin dose, and they had shorter hospital stay. So nowadays we are practicing this particular, practice of the diabetes insipidus. This was published in JCN, Journal of Clinical Nursing, in the year of 2021. And this is another study where we have conducted another intervention. We initiated that. We introduced a nurse counselor. This is said to be published. So nurse counselor, impact of a counseling done by a nurse counselor on some of the outcome during the postoperative phase. So we appointed a nurse counselor who would identify the patient who is posted for pituitary surgeries and would counsel about the brief counseling about the diet to be followed, about the CSF leak, and about the problems that they can develop. Because otherwise, the nurses working in the ICU may have the tendency to treat all the patients, and similarly, and the patients also have that feeling that we are post-operative and we have to be extra cautious in certain aspect. And so the nurse counselor has educated the patient. So here patients in experimental group where the counselor had educated has shown less prevalence of polyuria, better natremic status, and less values of fasting blood sugar, and postoperative complications were also less, and duration of hospital stay was comparatively less among experimental group. So this also, so the nurses' active interventions really make difference in the postoperative complication outcome and the outcome show hospital stay, etc. Then postoperative nursing care continued to have continued monitoring of vital signs and overall condition of the patient till the patient is in ICU and in the ward. Then provide wound care or oral care, because you know that if the patient is having postnasal drip, okay, definitely they may develop a CSF, it will be frequent. Otherwise also they'll be having little bloody discharge, a drip on the postnatal, so they'll be having little taste of the blood in the mouth and all those things. So we should be providing frequent oral care to those patients, because when they start taking orally, they should not have that feel of the sense of smell or taste of blood kind of thing in the mouth, which they have reported. So especially that will result in nausea and vomiting when we start orally. So we can provide oral care using chlorhexidine and other things. Then progression of diet as tolerated from liquids to semi-solids and then solid diet, for which we don't face much problem. Encourage early ambulation of patient and decreases the assistance gradually. So that's what I told already. We are this year taking a process study by ambulating the patient from the first day. Then education on postoperative care instructions generally, and then monitoring for signs of infection and other complications like fever or signs of meningitis like headache and etc. During the convalescent phase, teach the importance of follow-up care and medication adherence, especially if the patient is having hormonal disturbance, then they would be on different hormone supplements. Then continued wound care as needed, gradual return to normal activities, management of any lingering pain or discomfort, and they may be having some cyanonasal symptoms which they continue to have. We have to make them understand that it will take some time for them to recover from that because of this surgical approach. Monitoring for signs of complication and reporting to healthcare provider immediately. These are some of the tools that we use to assess. This note we use to assess during the postoperative phase to assess their cyanonasal symptoms. And it has a score with the 22 items. And then visual function scale, again to assess the visual quality of life postoperatively. Even in our research studies, we used this scale. And this NPIQ, that is neuropsychiatric inventory scale, we use to assess the behavioral symptoms because they are stress, anxiety, etc. And then WHO quality of life scale we use to assess the overall health-related quality of life. And we have seen that in this note, and cyanonasal and visual quality of life improves, that also lead to improvement in the overall quality of life. This was another study which we conducted to just assess the long-term complication, the compliances, medication compliance and long-term health problems in these patients. So the result showed that tumor recurrence occurred in 30%, and major long-term complications like unilateral blindness, hemianopia, headache, speech deficits, hemiparesis, etc. continued to be. Hemiparesis was there in 10% because these patients were, I think, they had apoplexy. And these other symptoms the patients continue to have. Now, these are some of the cyanonasal complications like assess for swelling and bruising around the nose and face, sinus congestion, nasal drainage, hyposmia. They'll always have, for a few months, they'll be having a feel like that cold nasal congestion, cold type feeling or flu type feeling they may be having. Report frequent swallowing and nasal leaks, as this may be cerebrospinal fluid. If the leak is there, then 30-degree head and elevation can be there for 10 days. And otherwise, that's like if the patient had a CSF during the hospital stay. Avoid sneezing and coughing, and if they are present, then do with mouth wide open. Then avoid straining, and if the patient is having any constipation, we can administer some stool softener. And if they can use some nasal sprays of normal saline or something if they have dryness. And then visual field complications. So as I told, if the oculomotor nerves are affected due to the lateral invasion of the tumor, there will be blurred vision or double vision, or and if the optic nerve and loss of peripheral vision, and visual acuity will be definitely lost if the loss of peripheral vision due to optic nerve, optic asthma compression. So, however, they have to, this visual symptoms may be improved if surgery is done immediately or in a short duration after the tumor identification. The surgery is done or the symptoms were persisting for a long time, the improvement is minor. And provide bright lighting during transition between rooms, focus area lighting directly on the activities like cooking, reading, etc. You can provide large print items or magnifiers to put less strain on the eyes. Organize drawers, almirah to facilitate functional performance. These are some of the tips which we can help the patients with vision complaints. Encourage eye muscle strengthening exercise. This is another study which we have done on RCT, which we have done to assess the effectiveness of nurse-led visual rehabilitation on visual outcome and quality of life. Here, we had developed some of the visual exercises, eye exercises, and the nurse had taught the patients. Usually this was not in practice. And so at the time of discharge, which included eye scanning exercise, eye muscle strengthening exercise, and oculomotor skill exercises, etc. And compensatory strategies like enlarged print, high contrast background, black on white or white on black, scanning tasks, saccading tasks, etc. And then neuroplasticity-based interventions. So these were some of the, interventions. Provide visual, verbal, tactile cueing, walking while scanning. So these all interventions were included. So these were some of the compensatory strategies which we felt that really worked. Like the keyboard is being designed with yellow and black or white. And see, this kind of scanning can be done, how to scan to identify the things, etc. So we found that this enhanced the visual quality of life and overall quality of life of these patients. And here the main why I have highlighted the compensatory strategies. We know that this whatever the nerves wherever improved, we can't do much to that, but compensatory strategies can help them to improve the quality of life and the way they live with. So this was the main aspects of the postoperative nursing care. The complications such as CSF leak and the DA and rest of the care, which we already discussed, and postoperative medication need to be continued, and then visual and sinonasal quality of life measures to improve that we need to do. So, nurses have to have really good knowledge on that. So coming to the recurrence of pituitary tumor, so we know that the regrowth of the lesion after surgical removal of pituitary adenomas is common, and it may happen 30 to 40%, and it depends on the several factors like tumor complexity, how much invasion was there, and how much tumor was possibly removed, and tumor location, and if some of the sinus cavity and all, if it is invaded, then we won't be able to remove it fully. And so these all the factors that can lead to tumor recurrence. And the treatment of recurrence may include reoperation or gamma knife, radiation therapy, etc. So here we provide gamma and stereotactic radiosurgery for the patient, residual tumor, or the patients who are having tumor recurrence. So that was about my topic mainly. So nurses must possess high competence in monitoring and providing perioperative nursing care to patients undergoing surgery for pituitary tumors. Thank you so much. Hope we can have some discussion.
Thank you, Dr. Manju. It's nice presentation. So I will invite Dr. Selfie to give a comment.
Sensei, maybe you can make some comment for the two nurses. Presentation, please. Okinawa, please speak loudly.
Can you hear me?
Prof, we can't hear you, Prof.
聞こえてます？
大丈夫。あ、すごく良くなった。
Okay, okay.
Much better than before, yes.
I'm so amazing. High CS leakage, 40%. That's amazing. Please ask doctor, please reduce the CS leakage. And my comment is, do you know the hyponatremia? Why it happened? Most frequent cases.
Hypernatremia?
Yeah.
Hypernatremia.
I think after the surgery, during DI, the nurse often said to patient, please drink more and more. And patient believe nurse more than doctor. So if nurse say, please drink more and more, patient believe drinking is good. So most of the cases of SIDH hyponatremia is because of the much drinking. So after I restricted the 2 liter per day after the surgery and request the nurse, please don't say drink more to the patient, SIDH hyponatremia reduced. Of course, seldom occurs as hyponatremia, but please don't say to the drink more and more. That's a comment.
Drinking more. So like we have a habit of giving juices and other things. So we just told them, if they are feeling thirsty, just drink water for just compensating the thirst, not excessive drinking. And to avoid all the fruit juices and drinks with salt or sugar during the postoperative day. Not excessive intake. So
Maybe Dr. Selfie or is here. Maybe can give some comment.
Okay, thank you. Congratulations. It's a very thorough and complete and detailed presentation. May I ask a little bit more about the visual rehab? Because I think it's very interesting and I don't think a lot of institutions already doing it. So in which kind of patient would you start and when to start the visual rehab? Thank you.
This is a study which we have conducted last year, madam. Actually, so here the routine protocol was that after the surgery, the patient would be discharged and they would be following up in neurosurgery OPD. And if the patient is having endocrine anomalies, they'll be following up in endocrine OPD as well. So they are never going for, that some of these patients having vision problems. So, but they are never followed up in an ophthalmic OPD, ophthalmology OPD. So here, so like we know that these problems of vision, like whether it is double vision or peripheral vision loss cannot be completely regained, like whatever muscle strengthening exercise, etc. we teach. So though muscle strengthening exercises are there in our list, so we have taught them some compensatory strategies. So we have developed the strategies with the help of ophthalmologists only. They are following for the ophthalmic patients who are having vision loss. So this were not taught, never taught, and there were not much literature for the pituitary patients on this aspect. So we have developed a booklet which contains all these exercises, and we provide that to the patients at discharge. And during the postoperative phase itself, we started teaching them. So if we get a counselor, we will be even teaching them during the preoperative phase only, but it is like their admission, very short duration of admission preoperatively, or they just come. So we don't get much time to train them on that. So during the postoperative phase, once they are stable, we teach the patients and the caregivers. So they feel it is the visual quality of life when like how they adjust with the vision problems. We know that the problems can't be completely recovered, so they are more satisfied with the intervention.
Wow, congratulations. If you have some more detailed paper or protocols or the booklet that you can share, I think Nurse Enoch will be more than happy because we do have a like a foundation based on the pituitary patients in Indonesia. And I think they often ask about this, and we are trying to coordinate with our ophthalmologist, but I don't think this thing is like available in each hospital. So if you have a booklet that can be shared, I think that will be great. I think a Nurse Enoch will be agree with me. Congratulations, by the way. Thank you.
Of Kurosaki, can you give your comment?
Okay, thank you very much for a nice presentation. At first, I was so surprised to hear the word visual rehabilitation. Do you usually perform the visual rehabilitation post-operatively?
Yeah, it is a new technique that we have started just last year. So it was never followed before, or we don't send them to a rehabilitation center or rehabilitation unit or anything. This is because there are no one is physiotherapist. They are not doing, or the ophthalmologist. We are not collaborating with them. Maybe post-operatively, I think that should be basically done. I think so. Here it's a nurse-led intervention. So the nurse is training, because these are the intervention. The nurse is trained on performing and training the caregivers on this intervention. She got trained from an ophthalmologist. So she just teaches during the post-operative period before the discharge. So
thank you.
That's what.
And the other question is about the patient with the how do you treat, how do you care with the patient who have the diabetes insipidus preoperatively?
Yeah. Actually, that's what I told. Like post-operatively, they are at risk of developing diabetes insipidus, and so we just tell them to during the post-operative phase, from the as soon as the orally patients are started with orally, to avoid the diet and the drinks with which contain salt and sugar. Especially in the initial period, so that so when we compared post-operatively, the total output in these both categories, like we found that the patients who followed this bundle or the instructions, and if they are feeling thirst, they can just drink water, not excessive water, just to quench their thirst. So we found that the total diabetic, urine output was significantly less in the group patients who followed this, and the occurrence of hypernatremia was less in this patient. So that's what, like we told them to, because when the patients are post-operative, when we tell them to start orally, caregivers, family caregivers are the one, because we are not providing, though hospital's diet is provided, the patient's caregivers also will be supplementing something. No, they'll be bringing juice, they'll be bringing protein supplements. This kind of things will be provided to the post-operative patients. That compassion and so that we have to tell them to avoid.
Thank you.
Thanks.
Prof. Kato, do you have any comment?
Yes, thank you so much. So we learned a lot about the pituitary lesion, the surgery. So I think nursing care is very, very important, because you are taking care of the patient 24 hours. I think that means is you should have more knowledge, and maybe you can exchange, the basic knowledge and skills, I think. And maybe Dr. E, Miss E, I think you should have one more chapter of the Miss Selfie that she mentioned about some kind of guideline how to taking care of the nurse treatment management of the pituitary lesion. I think it's quite useful, I think. So I thank you very much for all that you did the last 1 year. So that I think ACNN expands a lot. Great effort of the Mrs. E. I think she went to many places, the Neurosurgical Congress. I think maybe all the time that she mentioned about some role or what the ACNN has done. I think it's very, very important, such kind of announcement in the world, I think. Maybe I think the ACNN will have a more membership more member, such as especially the younger nurses, and we teach each other, and also that we can have such kind of excellent teachers, such as today is Amano Sensei or Kusaki Sensei, not only Japanese, but also but anyway, the Japanese neurosurgeon is more than 10,000. There's so many neurosurgeons, I think, that you can choose many excellent doctors from Japan, I think. So thank you so much. I think I wish you a very happy holiday time. Happy New Year. Thank you very much.
I think we have come to the end of the webinar. Thank you very much to all of you and for the support, especially Professor Amano, Professor Kurosaki for the last minute changes, and Dr. Selfie. Here I wish to thank everyone again and wish everyone a very happy new year in 2 more days' time. And hope we will continue to get all your support in the future. Thank you very much. Hope to see you all again. Thanks. Bye-bye.
Yes. Thank you. Bye.
Bye.
Sensei, Kurosaki Sensei,
Bye-bye.
ありがとうございました。
Thank you,